Thank you.
Dr. Sahu's 2mm MSICS Ergonomics. Dr. Nilutparna DEORI is from Assam, a brilliant surgeon, dedicated surgeon also, and I thank her for confirming with my postulations, and she developed the ergonomics and whatever. Yes, Nilutparna.
Thank you, sir. Very good afternoon to all of you. Thank you, APAO and AIOS for giving me this opportunity. I would like to thank MSICS for giving me the responsibility to tell you something about the wound ergonomics of 2mm MSICS with back incisions. I do not have any financial interest in this presentation. So as we all know, we are looking at 2mm incisions, but I would like to say that this is an advanced MSICS technique which has got 2mm curvature on your scleral incision only, but then you need to place 2 parallel incisions on either side of the 2mm, which will help you to create the pockets once you enter the cornea. So with this algorithm, I am showing you this schematic diagram. In this diagram, this incision is placed 1.5mm behind the limbus, and that 1.5mm incisions are placed on either side of the incisions. Of the main incision. So you when you are creating scleral pockets, you need to understand that the scleral pockets are going to go into the cornea up to 1.5mm. And this incision, since it is a curved crown incision on the outside, so we need to keep in mind that the entry into the corneal wound will be parallel to that of the limbus. So I have made this incision, as you can see, distance of 3 to 6mm. Now the reason why I have done that is that in order to manipulate or maneuver your instruments, that is the vectis and the nuclear fragment in the tunnel, you need to at least expand it to 3 to 4mm. Why? Because the cornea is not expansile as the sclera. The elasticity of the sclera is more. So you get the advantage in the sclera, but you do not get the advantage in the cornea for that matter. And we have numerous papers, especially one by Singer, which says that you can introduce a PMMA IOL even through a smaller scleral incisions. So now to understand the physics of the procedure, we have created a model like this where the object 2 is the nuclear fragment, object 1 is the vectis that will be in the tunnel at one point of time when you are going to take it out, and the red arrow shows the direction in which it is pulled. But I will explain it to you later on that this is not the ideal direction that should be used, and the surface is the scleral bed that you have created once you have made the corneoscleral tunnel. And the force T on either side is the tension that will be acting on the 2mm incision at all points of time. In order to reduce the stress on the 2mm incision, you need to create the back incisions and create the side pockets along the back incisions. So as I have explained, we have the elastic region of the eye, that is the sclera, and the plastic region of the eye, that is the cornea. By means of the Hooke's law, we know that when the stress is within the proportional limit, the membrane will return to its original length, that is the scleral wound, when the objects are out of the tunnel. But if it crosses the yielding point, that is the point C, then you will see that there will be fraying of the ends of the tunnel, there will be fish mouthing of the scleral wound. So if you want to have a good wound integrity, you need to understand this point before you go ahead with the surgery. This has already been shown by my previous speakers, the instruments that you want to use. So I'll go ahead with the surgery. So this is a 2mm marking that we have done, 1.5mm behind the limbus. You make an incision here, and then you place the side incisions on either side of the 2mm incision. Now if you do not have a 2mm crescent, go sideways on either side. Now why I am saying this, because if you want to create a 2mm and go with a larger size 2.8 or 2.2mm crescent, you will actually cut the ends and you will end up with more than a 2mm incision, because since your sclera is elastic, it will give away, but it will not, it will again contract back when it is healing. So you are actually not doing a 2mm incision, you are actually making a 3 to 4mm incision. In order to avoid that, these back cuts are very important. It is also good if in this situation you are ambidextrous, so that you can use both hands, because this is a very small incision. Now this is a 2.81, so that is why we have gone obliquely or diagonally. So once you have entered it, See, we have created a parallel incision now, but I have increased it here. Here I am planning, according to Singer's hypothesis, that I am going to implant 5.5 optic PMMA IOL. Now, when we are trying to fracture or fracture the nucleus in the anterior chamber, we need to keep in mind that the visco cannula has to inject visco throughout the process so that we do not injure the endothelium. And you have seen that at single go, the one fragment of the nucleus has actually come out. So even at the end of the surgery, you have already created a tunnel, and the successful execution of the process, that is pulling out of the pieces of the tunnel without tearing the scleral tunnel, won't indicate that all the stress that is developed in the scleral membrane was within the elastic limit. So now let us do the analysis. The size of the nuclear pieces and width of the tunnel. This can be explained by the Pythagoras theorem. I have used a very simple theorem to explain this to you. That when you have that the stress is equal to the restoring force and the area that is occupied. So the amount of stress will keep on increasing if you increase the restoring force. That is why you increase the area so that you reduce the stress. Now as you go behind, you will feel that as the L decreases, the restoring force T increases. So since the stressing force T experienced by the membrane is higher near the scleral incision, the only way to keep it low is to proportionately increase the area, and which we have done by making the pockets on either side. Now we'll analyze the width of the tunnel. Now since the restoring force increases with the size D of the nuclear piece, so you cannot bring out the nucleus in toto, you have to divide it. Otherwise what will happen, you have not created, in this GIF you can see that I have not created the back incisions before taking out the nucleus. So what has happened, you have actually created a fish mouthing, and when you have created a fish mouthing, there is a purse string effect on the entire tunnel that will pull, that will act at that point in the tunnel. So you are not having a 2 mm incision anymore. You are actually having more than a 2 mm incision, and that too with frayed ends. So therefore the minimum length of the tunnel and the maximum size of the nuclear piece and the minimum thickness of the scleral membrane is such that the stress is below the scleral limit. We have another paper from the Indian subcontinent by Dr. Ashok Nanda et al. Who actually described regarding the thickness of the scleral tunnel. So you need to understand that when it is at least 1/3, or if it is a little more, you will have less stress on the wound. But you cannot go beyond, you cannot increase it to 400 microns and so on and so forth, because otherwise you will have a premature entry. So now how do you pull the vectis? So when you have entered into the tunnel, and now you have the vectis and the nuclear fragment in the tunnel, not inside the AC, but in the tunnel. At that point of time, you will have another two forces acting here. One is the horizontal force that is on the ends of the incision, and another is the weight, that is the sine alpha and the cos alpha forces. Now you have negated the cos alpha forces here because you have already created the side pockets, but you cannot negate the sine alpha forces because it will double up now. Why it is doubling up? Because you have the vectis, you have the nuclear fragment inside the tunnel, you need to pull it out. So for the horizontal pull F given by the vectis, the friction N between the vectis and the scleral membrane will cover the weight of both the objects 1 and 2. Hence the material of the vectis should be lighter, and in order that the acceleration of the nuclear piece
can you sum up please your conclusion?
Should be less than that of the sliding force. So you need to have viscoelastic inside. So now you cannot have a horizontal pull at all points of time. In order to reduce this friction, you pull it at an angulation where there is a little upward push and a horizontal push, such that the scleral tunnel is not injured. So this is the right way of doing this incision to have a clear cornea on the next day and a good wound integrity. But if you create a 2 mm and do not create the side pockets, you will end up with iris prolapse, you will have corneal edema. And this is what we have realized after our experience at 2 mm, and we feel that astigmatism, wound integrity and the corneal endothelial count was valued in good limits. So thank you for your patient hearing.
Thank you, Nilutparna.